Since we've made a diagnosis of IPF, we now should think about treatment strategies. I'm going to focus on pharmacological therapy with Nintedanib and Pirfenidone. I'm going to talk about some guidelines, and I'm going to talk a little bit about lung transplantation. In 2011 and again in 2015, medical guidelines were issued for the treatment and management of IPF. These came from 4 medical societies: ATS, ERS, JRS, and ALAT. And when we put the guidelines all together, we get some good information and help. The first thing is that strong recommendations have been made for the use of oxygen and lung transplantation in appropriate patients. And conditional recommendations have been made for the use of Nintedanib, Pirfenidone, Antacid therapy, and pulmonary rehabilitation. A quick note about a conditional recommendation: that doesn't mean it's a temporary or even weak recommendation. It ought to be interpreted as these are treatments that many patients will want, some patients will not want, and we need to engage in a shared decision-making process and work together with our patient to figure out what's best for them, as we do in most cases. The guidelines also made recommendations against certain therapies, and this also really helps inform practice. For example, the guidelines made recommendations, and strong recommendations, against the use of anticoagulation, specifically with warfarin, triple therapy, which is prednisone, azathioprine combined with N-acetylcysteine, and ambrisentan, because of clinical trial data indicating harm. I will say that anticoagulation in that clinical trial was studied as a treatment for IPF specifically compared to placebo, with increased rates of mortality. However, if your patient has an indication for anticoagulation, such as venous thromboembolic disease or atrial fibrillation, please anticoagulate them as indicated. The guidelines also made conditional recommendations against the use of macitentan, bosentan, sildenafil, and monotherapy with N-acetylcysteine. Let's focus now on 2 antifibrotics that are FDA approved for use in the United States to treat IPF. They are Nintedanib and Pirfenidone, and they share many similar qualities. They were both studied in double-blind, placebo-controlled, multinational clinical trials. Nintedanib was the Impulsus 1 and 2 trials, Pirfenidone in the Ascend trial, and before that, Capacity 1 and 2 trials. Both enrolled patients with IPF who had mild to moderate disease severity, as indicated by a forced vital capacity greater than 50% predicted. And both drugs, each compared to placebo, showed similar efficacy signals. And that signal was a slow in the rate of progression by 50%. So unfortunately, that means that people aren't getting better or even necessarily remaining stable for the rest of their lives. Even on treatment, people progress. However, they progress more slowly, which can have a clinical impact. There are also signals that these drugs may reduce the risk of acute exacerbation or respiratory hospitalization. And even in meta-analyses, there may be trends and signals towards reduced all-cause and treatment-related mortality. In large network meta-analyses and in other pooled studies, we see these trends that Nintedanib and Pirfenidone are both more effective than placebo at slowing FVC decline. We also see that when we can, in a network meta-analysis, which is a fancy way of being able to compare 2 therapies that were never studied against each other, that there's not really a major difference in efficacy between Pirfenidone and Nintedanib, which makes sense because they both seem to have the same efficacy signal compared to placebo. One of the major factors that comes up in clinical management, both during initiation of therapy and during maintenance therapy, are adverse effects of the drugs. Nintedanib commonly causes diarrhea. It is often manageable with loperamide. Dose interruption or lower dose, there is a lower dose available. Nausea, vomiting, less commonly, but can occur. There's also been some post-marketing reports of drug-induced liver injury, pancreatitis, thrombocytopenia, and a theoretical risk of GI perforation since it impairs certain growth factor pathways. Pirfenidone, on the other hand, doesn't have diarrhea as commonly, but does have upper GI side effects such as nausea, dyspepsia, loss of appetite, GERD symptoms, and can induce a photosensitivity skin reaction. So for both medications, there's a fair bit of counseling that has to be done with the patient about how to take the medication. Pirfenidone needs a dose titration. Both medications absolutely have to be taken with food, much better tolerated. Sometimes we need to add additional medications to help them tolerate the medication. I will put everyone on an antacid if they're going on pirfenidone to prevent some of the upper GI side effects. Sometimes they'll need ondansetron or something else for nausea. As I said, loperamide for nintedanib. And as I said with initiation, talking to the patient up front and deciding between one drug and the other is often all about side effects. Which set of side effects is more acceptable to your patient? But there are also other factors. For example, with nintedanib, either avoid it completely or very closely monitor patients who are on full-dose anticoagulation or dual antiplatelet therapy because of a theoretical increase in bleeding risk. In addition, those at high cardiovascular risk, nintedanib may not be appropriate. There is a small signal of increased myocardial infarction in the IMPULSIS studies for those taking nintedanib. Very small, but present. Pirfenidone, on the other hand, doesn't necessarily have the same set of concerns, but a different set, and that's drug interactions. Pirfenidone should not be taken with fluvoxamine, an antidepressant, because it can raise pirfenidone levels. Similarly, high-dose ciprofloxacin, which of course is not commonly used, but that should be avoided in people taking pirfenidone. And then people who are currently smoking, smoking will lower pirfenidone levels. And so in addition to, of course, smoking cessation efforts, pirfenidone may not be a great choice in people who are currently smoking. There's also a little bit of controversy around the recommendation to use antacid therapy to treat IPF. This conditional recommendation was based not on randomized trial data, but on observational data, which is intriguing. There are non-randomized comparisons between IPF patients taking antacid therapy and IPF patients not taking antacid therapy, and showing that those who were taking antacid therapy had a slower decline in lung function, and even in one study, maybe even a reduced mortality rate. There's other data suggesting that that didn't occur in other cohorts, and there's even one study suggesting that antacids might increase the risk of respiratory infections in IPF. So there's been some contradictory data, and some of that data follows those recommendations after the year 2015 when that came out. Now, in 2018, the WRAP-IPF study was published. This was a phase 2 trial of surgical fundoplication to treat patients with IPF who had objectively documented GERD, as documented by a Demister score over about 14. In this trial, those randomized to fundoplication had a non-statistically significant reduction in the rate of decline in lung function over 48 weeks. Now, so just to be clear, the lung function decline was slower on average, but not statistically significant. There were some secondary endpoints, time till decline in lung function or death, and others that did show intriguing trends in the right direction. I think the jury is still out on whether or not aggressive treatment of reflux with surgical fundoplication is indicated. I guess we'll wait for the next set of treatment guidelines to help sort that out. Certainly, it's not something that should be used routinely in all patients. Now, a couple of other things we do for our patients, of course, supplemental oxygen certainly improves exercise capacity and improves acute dyspnea. And this has been published. Of course, in individual patients, we certainly see in some, but not all cases, that adequate use of supplemental oxygen in the home, outside the home, can relieve dyspnea, and at least patients subjectively report less dyspnea. Pulmonary rehabilitation, as recommended by ATS, also very important. It can improve quality of life, improve exercise capacity. It may not have the same lasting effect as pulmonary rehab does for, say, a patient with COPD, but it still can have a positive impact on their lives. I prescribe pulmonary rehab to patients if they need any oxygen. So if they need 2 liters when they're exercising or 2 liters when they're walking, I will send them to pulmonary rehab at that point if they're agreeable. And then I want to just have a word about lung transplantation. This is an excellent treatment for highly selected patients with IPF. There are not a lot of lung transplants performed. In 2017, there were just under 2,500 lung transplants performed in the United States, and maybe just shy of 1,000 of those were for people with interstitial lung disease. So there's not enough lungs to go around. So we highly select these patients. If your patient is fit, physically fit, has very advanced lung disease, A lung transplant may be able to save their life or prolong their life by years. The median survival time is 5 to 6 years. For older folks, older than 65 or 70, it's not going to be quite that long on average, but may still be beneficial in selected candidates. And the International Society for Heart and Lung Transplantation has issued guidelines on the timing of referral for lung transplantation. And the bottom line is, if your patient has fibrosis, you should refer them for transplant. That may mean you're referring people early in the course of disease. That's okay. It's never too early to refer. They get to meet the transplant program, learn about it, get accustomed to it. As their disease progresses, they will then undergo additional testing, including invasive testing, and see if they're a candidate for lung transplantation. Don't wait till they're on 12 liters of oxygen. Don't wait till they're in the hospital with an acute exacerbation. Try to send them much earlier than that. Anyone with reduced lung function, anyone who needs oxygen, anyone with IPF, anyone with established fibrotic lung disease that is going to progress should be referred for transplant. Again, at the time of diagnosis or shortly thereafter.